It is the 20th of August. I am Matthew Holt, your host for the THCB Gang. It's episode 22. Have a great, fun lineup today. It's going to be a good fun fight, great discussion about the state of affairs in healthcare and the world this very day in August with the THCB Gang. Who have I got on today? Well, a great bunch of regulars with a person who's been a guest before, but is squeezing away into being a regular here. We'll start with her. That's Casey Quinlan, who is at Mighty Casey Media, patient advocate and general
activist,
advocate, loudmouth.
I cause trouble.
Talking over the part, even talking over the part where she's not supposed to talk about in the intro. All right. Alongside Michael Millinson, patient safety expert, president of Health Quality Advisors, Devin McGraw, chief regulatory officer at Citizens, startup in Silicon Valley, but formerly a government bureaucrat and probably one of the best known people in health technology and privacy. Kim Ballard, regular contributor to THCB, editor of the late lamented Tincture and former blues marketing exec, and Raj Agarwal, token other Brit on the line, guy who runs Jefferson's Innovation Strategic Ventures, and also sometime bariatric surgeon. All right, so let's go. Quick drink of water for me to say hi to everyone. I hope everyone's having a good day, and no one's in a place apart from me and Devin that's burning down.
Not so far.
Not so far. It's actually not, but so it was pretty scary in the Bay Area until it still is pretty scary, but seems to have cooled down a little bit today. We are, I don't know, there's plenty of other stuff burning down. We've had socially, and we've also had the Democratic.
The entire world is a burning platform.
So let's go around the horn, ask people what they've seen in the last week or two that's piqued their interest, and we'll start with you, Kim.
Well, I just find it interesting that in Ohio, it's safe for high school football players to play, but it's not safe for Ohio State football players to play because of COVID. So I can't really wrap my brain around that.
Well, maybe the high school players aren't as susceptible, or maybe they don't breathe in and breathe out when they play football. Who knows? All right, that's quite an interesting one. Devin, what have you seen this week that
I was afraid I was afraid you were going to come to me first. You know, we're still sort of seeing that the use of technology to help with COVID contact tracing is not really taking off in ways that people thought it would. Although now I just read an article early this morning that the hope is that as you know, college students are coming back on campus, many of them are arriving as freshmen for the first time, that, you know, well, they're tech savvy, and it's likely that they will use these apps in ways that could help control the pandemic. And of course, we'll see about that. But it's really interesting. I mean, I got phone calls about, you know, the Google and Apple partnership, and I got phone calls about contact tracing apps really probably back in May, and it was a whole like hullabaloo of activity and what do we do and privacy considerations and lots of interesting conversation. And it turned out it's almost like a big fat nothing burger. Like it just is not something that's being used in a widespread way. People are not, it doesn't feel like people are using it, whether trust is the issue or just more that there's not really a product market fit, right? Like the public health departments are not sort of prepared to use them effectively. And so people don't really feel like using them for no real clear benefit. So, but that's been interesting to me.
Yeah, and I think one of the things that I've noticed is that there's still question marks about what's going on with Palantir and the change from the CDC to reporting hospitals infections, reporting COVID rates direct to HHS. Now, I hear rumors it's going to go back to CDC now, but so that's what we're going to talk about a bit more about that part when we get to into the meat of the show. Casey, what have you noticed the last couple of weeks that really struck your attention?
Well, speaking of COVID contact tracing apps, the one that was launched by the state where I live, Virginia, I'm suspicious of, you know, automagic anything having to do with my phone's location as a founding member of the Light Collective. But I took a pretty hard look at this particular app. I did download it, and I am allowing it to send me notifications. It has not sent me any notifications, despite the fact that it seems to be sending people that I know lots of notifications that are terrifying them, but they're not sending them to me. That's fine. 300,000 Virginians have downloaded it, which I found both encouraging, because this one works apparently, like, if you believe everything you see, including in the code, and I didn't go as deep as perhaps other people would, but it uses Bluetooth only. It does not ride on the geographic location of your phone. So that was a little bit more, I don't know, calming for me and made me actually download the thing. The other piece of public health here in the state where I live, Virginia, that is a little problematic still is that the Virginia Department of Health, the guy who's the head of it, keeps saying that for some reason, probably it's because HIPAA, but for some reason, reporting data on COVID infections in nursing homes in this state is still something he really doesn't feel that he can do publicly. And it's like, I want to kill the guy. But meanwhile, I'm, you know, but well, the General Assembly's in a special session right now, and they're planning, I think, on bitch slapping him on this. Stay tuned for updates.
All right. Michael, what do you say?
So, you know, if we want to increase use of the app in college students, I suggest that we put a COVID app that rides on Tinder. That might be the adaptation mechanism. I think to me, what's fascinating about the COVID app on the Back to Work is Fitbit's Ready to Work, which I tried to ask them who's actually using it. They're selling it to employers. They didn't give me any customers, even though they announced it, I think, in June. But what's really interesting about that is they have a dashboard for the employer. So all of a sudden you have people who are supposed to use this, are supposed to get out to the workers, see whether they have symptoms. And the employer has a dashboard about who's ready to come back or whatever, which is pretty interesting and hasn't gotten any attention. Not exactly a public health kind of group. Meanwhile, on the football analogy, like Kim said, I think the healthcare system as a whole is kind of like southern states on football. On the one hand, they want to pretend everything's back to normal. On the other hand, they kind of know it isn't. And that's where sort of the healthcare system, I think, is going. They'd love to get all the patients back in and have precautions, say everything's great. Let's open up the cash flow spigot again. But deep underneath, they know that might not be the best idea.
The coda to that is some Southern football coaches are saying that the students shouldn't come back to campus because it would be dangerous for the football players who are on campus. So they got
well, at least they're admitting one of the
priorities, man. Priorities.
Priorities, all right. All right, Raj.
So I have two. I have one international one. So I'm sure all of you know that August 15, Saturday, was Indian Independence Day. And on that day, the Prime Minister of India, Narendra Modi, made a announcement that he is launching the country's National Digital Health Mission, which is essentially going to be a digital health ecosystem where every Indian citizen is going to have a unique health ID, digitized health records, registry of doctors, facilities, and so forth. That's all the information I could find out on it. Really interesting. Obviously, this was tried in the UK, spent over $10 billion and didn't work. And so it's 1.38 billion people now going to be on a national digital database. It's mind-blowing. I'm forever the pessimist on this. It's a political thing that he's doing, but interesting. So that's the international thing.
Actually, just on that one, Roger, I think Nish Chopra once told me that was the fastest rollout of any technology of any technology ever to people. The actual, the original ID, because the ID's been out for a few years. They've been rolling it out for a while. And I think what this one was rolling basically services on top of it. They said it was going to do a bunch of stuff, including telehealth and who knows what else is going to be on it.
Right.
But hell of an interesting idea.
Yeah, it's like, you know, who's going to do it out there? I don't know. Or the companies in India, or is one of the big five going to do this? And obviously there's privacy and security issues there as well. So that's the international. But Philadelphia, very specifically, I just got a text from the city of Philadelphia about COVID. As of today, bowling alleys, movie theaters, and other indoor facilities are open. And as of September 8th, indoor dining is going to be open. Very interesting.
At what capacity?
25% capacity for indoor dining and movie theaters, and gaming arcades as well is in there. So yeah, just as my kids are about to go back to school, all the fun stuff's going to open, right?
Well, I'll fill in with what I've seen this week, and there's a bunch of stuff going on. There's been some data this week about, there was last week and this week some data about how, and we'll get into this perhaps with Raj in a bit, about how some hospitals are coming back to full capacity on elective surgery, including UCSF, how some hospitals made a lot of money in Q2. Every health plan made a lot of money in Q2. Some hospitals did, but some didn't. Providence came out with some semi-decent losses, and it's a mixed picture on how that's going to play out. Is a lot of interest. And also this week on the new THCB book club, I talked to Raj's boss about his new ideas about which will probably cause Raj a lot of problems in the future. I don't know if you read his book or you're not yet, Raj.
Of course I have. Come on.
Come on. Really?
Yeah.
I've got it here. What's on page 47?
I put it on LinkedIn, and literally within a day, about 7 people said, "Oh, that's great. I'm going to buy it." So I think I need a cut from Steve.
You need a cut. So Steve Klasko is the CEO of Jefferson, has written a new book with Hemant Taneja. Hemant's the VC who put money in to Livongo and has now decided, because he got that one right, he's going to change the whole healthcare system, and he may do, right? Also put money into Row, the online pharmacy, and there's a spate of those. And this past week, and that's my other piece. This past week, there's been another spate of investment in really niche products on the consumer health angle, and the question about how we're going to do healthcare in the future has really risen its head. Johnson & Johnson put in money to a company called 30 Madison, which doesn't have one website you can go to get your baldness pill or your erectile dysfunction pill or your GI problem pill. It has a website per condition. One's called Keeps, one's called Cave, one's called something else. I forget all the names, but I mean, the way that we're starting to deliver healthcare online to cash-paying consumers is going to be changing a lot. Anyway, so that's kind of the wrap for the week. Let's go back to kind of where Devin and Casey were starting, which is around this reporting issue. I don't know if does anyone on the line on the gang today know a bit more about where we are with this issue of the reporting going from the CDC to HHS in secret and then coming back, and Palantir's involvement? Devin, is that something you've been tracking?
No, I mean, I only saw that the chief information officer from HHS resigned, presumably over the pressure and the controversy. And this was not a political appointee. This was a career guy, which is really unusual. Makes me all kinds of curious, of course, about what the true, what really was happening behind the scenes and the true motivation. But that's a long-winded non-answer to your question. I have not been tracking it, whether, just the frustration about moving it in the first place, and the fact that we still don't have a handle on the data this far into the pandemic it's just beyond frustrating.
Yeah, I mean, I know that, and I can't remember the acronym for the database, but the database that was available via the CDC for hospitals, and this is like going back to the dawn of man, or the first server that somebody put in a basement. But the access to data, to hospital data for the hospitals that provide it, had been on this system that was under the CDC. But now that all the data is supposed to go to the HHS, they can't see their own stuff. They just send it in and okay, whatever. And I have not heard anything that sounded like intelligible English on this coming out of the HHS since this happened. So anybody got any ideas?
The couple stories I scanned today, the two takeaways I had were that Deborah Birx is now claiming this was always only intended to be as an interim solution, which it seems like rewriting history, and that they've hired some agency that helped with the rollout of healthcare.gov to make the input process less manual for hospitals. Now, why they didn't do that before, I don't know, but it looks like they're trying to whitewash this whole thing, pretend it never happened.
Okay, we'll have to page Andy Slabbit and figure that one out. Perhaps he and Todd Park can intervene and then start fixing stuff again. All right, well let's move on from that one. I am interested in sort of where we think, and and again, this is we don't have our epidemiology experts on this one, but where we think the current state of play is regarding COVID as a whole. The reason I asked that is that we seem to have, evidence of peaking. I mean, we were talking before we got on, Casey, about North Carolina and Virginia and some of these southern states. We seem to have evidence that those sort of hot spots in the South, Houston, elsewhere, peaked, but also that we had considerably lower death totals for the same number of hospital admissions. Well, maybe that's not true. And I just saw some data from the UK, or from Eric Tobel put some out, which I think was from the UK, which says that the same thing is true, that age-rated death has actually decreased over time. And I wonder, is that because, do we have any sense of whether we just improved how to figure out what to do, that the systems are less overwhelmed? And, what does this mean? I want to sort of speculate a bit for how this is going to play out, because we're now seeing places which even cured, quote unquote, coronavirus, like New Zealand, getting reinfected by who knows where. So does anyone have a comment for that?
How could anybody be surprised by this? Because, the sort of the mechanism of epidemics is not like it's a giant wave and it comes and it washes all over everything and then it goes back out to sea. No, that's not how it works. And New York is one example of some, a city that took it in the shorts. That had a lot to do, I think, with population density, and also the fact that the virus that managed to go across New York was from Europe, while everybody else was looking over at China going, guys. And as a result, there was, early on, because their problems emerged in, like, say, March into April was the worst and started to tail off in May. And now it seems as though the mechanism is, at least in the southern states, and not to a huge degree, but to a noticeable degree, it's affecting more 20 to 40-year-olds now than it was in previous high, waves of infection in Picken area, any area. And I honestly think that this virus is acting like a virus, which means that it doesn't have any brains, it doesn't have eyes, but it adapts to its surroundings, and it's going to keep replicating itself however it can. And if a bunch of kids go to a bowling alley or into a pool or, whatever, they're YOLOing out there, and or FOMOing, pick one, that's going to be the opportunity the virus is going to take, say, oh, okay, here's a whole bunch of places where we can go and replicate again. And
between Sturgis and Las Vegas, there are going to be lots of opportunities for everywhere in the country.
Dude, seriously. I called Sturgis the Darwin Award Olympics because, it's just, I literally said that on Twitter to Patton Oswalt. But Sturgis, any huge gathering of humans where everybody's getting in everybody's face and they're adamantly not masking, well, okay, your mileage may vary on your outcome there, dude.
Casey, in Florida already, when they tried to send people back, they had literally hundreds of cases immediately, right? And the problem is, so when at the Democratic convention last night, they were talking about how COVID disproportionately affects people of color, minorities, and everything. What they should have done is looked in the camera and said, and if you're a rich white dude, Boris Johnson. What they need to do is say, it's coming for you, Governor. It's coming for you.
Well, yeah, exactly. I think Boris is the poster boy for, if you think being a white dude of privilege gets you off the hook, not so much.
And in all seriousness, they need to, rather than emphasizing, yes, it is disproportionate, they need to emphasize the lack of socioeconomic status providing immunity. We see little anecdotes, right? We see a reporter here, a politician there, whatever, but we really, part of the reason we don't take it as seriously is, in fact, we've left an impression among the people who are not spending a lot of time studying this, that if you're not elderly and if you're not this and if you're not that, it's going to be okay. And in fact, it may be, or it may be terrible. And so the communication effort, sometimes deliberately and sometimes not deliberately, has led people to feel that they can get away with stupidity.
Well, this is, speaking, journalist to journalist with you here, this is the core problem in science journalism as it has been practiced pretty much everywhere all the time. There are exceptions, notable, excellent exceptions, but generally people, the receiving public, the people receiving the information want to know with certainty that X is happening. They want to know, everybody calls about, talks about the facts. Well, the facts are still a moving target often.
Exactly.
Because this is what we know right now today. And when you talk about science, it becomes even more squishy because, okay, this is what we know today based on this very deep dive. And yes, we studied the hell out of this, et cetera. But this is just what we know today. And then there's going to be the fist fights out there about whether or not your data was right. Yeah, I mean, but that's how science works. And that's how information works. And that's how history gets written. But most of us are not going to be around when the final word is written. And who knows what that's going to be. But meanwhile, it's a hot mess out here when it comes to information, both miss, dis, and do I trust this? So,
Casey, to pick up on that, the people, we as individuals go by emotion, right? I mean, we take cues in a certain way. And the people who are providing objective information are talking like this in their articles or on TV because we don't, and the people who are saying it's bullshit are talking like this with certainty and everything, right? So if you're listening to affect, you're getting an affect that says, I don't have to worry, as opposed to the affect that says, on the one hand this, on the one hand that, and who knows. And for people who are not on the one hand this, on the one hand that, who knows kind of people, what message do they get? So I think the old-fashioned objective journalism, which you and I might love, is not necessarily as effective in a pandemic.
No, it's not. At this point now, it has to be a drip, drip, drip. And you basically just cannot give up. You cannot stop. And it's not as though you can't shut up. Please do every once in a while, even I do. But I think you have to remain consistent. And if you're wrong, say that clearly in plain English and as loud as possible in the direction of people who might have been listening to the thing that you said that was wrong. And, because somebody said something on Twitter back to Matt when the announcement was made that I was joining today. And they were like, oh, the first time I met her, she mortified me because she was yelling at speakers on the stage. And I'm like, honey, I yell at anybody who exhibits dumb into a microphone. I hope someone does that.
Only happened to me about 4 or 5 times.
If I do that.
There is no vaccine for stupidity.
I'm waiting for somebody to do that to me. So please, I look at this as a group grope. So please, anyway.
All right.
I want to pick up.
Couple of things just to set us for a second. First off, Dan, I'm looking at Twitter. Dan Diamond from Politico, I think Politico is reporting that HHS is now denying the Wall Street Journal report that they're going to give the reporting system back to CDC. So who the hell knows? And I read a book, which I should have read a while back, but because it's one of my favorite authors. This is Michael Lewis, The Fifth Risk, which I happened to find. I went over to work with Jess DeMassa on a Teledoc Lavonda report. It's on her shelf, so I stole it. I wonder if she noticed. But it reminded me, I mean, you kind of know, but he went through it piece by piece about how little the Trump administration, when they came in, the people they sent to the departments like commerce and energy, the people who actually do stuff that matters, like run the weather service and run the nuclear power plants, and how little the people knew and how even less they cared. And I think it was a bit better at HHS. I mean, Devin, you were there for a bit during the administration. It was a bit better at HHS. But nonetheless, I mean, the malaise in general about how much these people care about how government runs. And by the way, the general griftiness, I mean, as witnessed this morning by not to worry, but both Bannon and Kurt Schilling have now been arrested.
I know. Well, the whole Bannon getting arrested on a boat by post office cops was kind of like, that was like the best 2020 apocalypse bingo ever.
If you got that one in your bingo card, you're doing very well. But I mean, what we're talking about, I think the basic problem we have is that I think if we're in New Zealand or somewhere, I mean, there are things people don't know. People don't know about the spread of the virus. People don't know about the method. We don't know enough, and whether there's an effective treatment or vaccination. We know some treatments don't work, but we don't know if there's going to be a vaccination and how that's going to play out. But at least there is some trust in what the government's saying. But I think what we're talking about here is that there probably is good reason to not trust large parts of our government because of the way it's been run for the last 4 years. It's not people you would naturally think believe in science and believe in sort of
anything
or in anything, if you like, Casey. So I understand why that's a problem, and yet we have this massive, we have the massive distortion, and literally that was the other part of my tweet about Tesla. This tweet that Matt's insanity is here. Tesla is now $2,000 a share, and the president is saying that QAnon are great people who love America.
Well, when it comes to HHS, anything that comes out of HHS, I will just say this: Michael Caputo is the director of communications for HHS. Just go Google that guy. And then that's all, that's it. That's the tweet. Michael Caputo is the mouthpiece for HHS. That's it. That's the tweet.
Well, so here's the thing about HHS. I do think that it has more appointees in it who actually are not don't come in with anti-government, actually came in with some legit healthcare experience. The problem is that every department is ultimately answerable to the White House. Exactly. And so ultimately, if you don't have good policy coming from the very top, it doesn't matter who's in the middle, who might be effective, they can't really do their jobs.
I want to agree with Devin. I mean, I think that when Trump first came in and you had Tom Price, he was a nut job who unfortunately knew exactly everything he wanted to dismantle. Like some of the people who've been over at EPA and all the rest of that, right?
Or the post office.
And when he managed to, fortunately to good journalism like Dan and others, self-destruct, Azar was a typical mainstream conservative who, valued government, valued doing things well, and generally was fine until the crisis came along, and then the White House got interested again, right? And once the White House crazies got interested again in the politics, Azar found himself overruled, and the people further down that Devin's talking about found themselves overruled. So as long as Trump wasn't interested, as long as you could talk about, accountable care organizations and value-based purchasing, their eyes would glaze over and you could do what you wanted. But when you started to talk about dead people from a pandemic, that was too simple for them, and then they started getting involved.
Well, and measures that would essentially have an impact on the economy, right?
Correct.
Nobody should go to work. Restaurants should shut down.
That's right.
That's not, that doesn't play strongly to the strengths that that the president feels he has in terms of, the economy was going gangbusters, best ever, like that, and so then you start to get the resistance.
And
most extreme.
Azar is a mainstream conservative.
Azar, yeah.
For instance, I don't believe he was ever a Fox News commentator. So right down, there's right.
No, I don't know that.
Okay. So I'm going to break us up here because we've been chatting about this for a while. I want to move us on. So the next thing I want to move on to is that this is the week of the Democratic National Convention. We are still seeing the polling data which suggests that a lot of swing states that were the ones that matter seem to be in the Biden column. There's a lot of discussion, obviously, about voter suppression and who knows what else going on with the post office, et cetera, et cetera. But nonetheless, I think most pundits are still pointing pretty resolutely towards a Biden-Harris win. One thing that I've not heard, we've heard the plan from the platform, and it's talking about expanding Medicare down to the age of 60. It's talking about introducing a public option. There's a bunch of stuff which sounds a little bit more ACA. There are two things that the one thing I heard this morning and one thing that I haven't heard. The one thing I've heard this morning is that the Supreme Court is going to rule on this lawsuit about the ACA apparently the week after the election.
Yes.
So I didn't hear much about that in the convention.
They're not ruling. They're hearing it.
They're hearing it. So
the ruling won't be until next spring sometime.
Okay.
Yeah,
so
they're not hearing it till after the election.
Okay. So we didn't hear much about trying to take the ACA away again and putting down the Republicans. The other thing I've not heard at all about is, and this is where I want to come to Raj, is a lot of the discussion I had with Steve Klasko and Amanda Tanger about their book is that it's kind of like the Economist sort of scenario. We're going to assume the following is true, and then we're going to have the following model. And if the following model is going to change the way we're going to do healthcare, the way a lot of us have been talking about with permanent monitoring and surveillance of sick people and chronically ill people and managing them in their home and doing hospital and home and moving away from healthcare in a facility to healthcare where you are, and all the kind of good stuff that people like me have been punting about for years. It does assume that we're going to change away from the sort of fee for service. Hospitals make their money on elective surgery. Doctors make their money on hospital on visits on office visits and doing procedures in the office and that kind of stuff. That's actually the facts of life today. So has anybody, and I'll turn to you, Steve says this is going to happen and therefore he's changing Jefferson, but also in this conversation, the conversation we had with him and Ant and Glenn Tillman, there was a fair amount about, well, yeah, that was okay for you as an employer, Jefferson, but not so good for you as a take it in of dollars from the insurance companies. Has anybody heard, something rational like we had in the background of the ACA from the current Democratic plan? I haven't had much conversation about this at all.
So,
Raj, you're on mute. Come off mute.
Oh. So I was saying this on a call, actually, that there are enough smart technology AI people. Why has someone not come up with some AI technology that monitors the video that when my lips start moving, it unmutes me automatically?
That would be lovely. Why don't let's get someone on that?
Right. Actually, it does tell you that. It says you're muted if you start talking.
It says you're muted, but
That's
just
not really
unmute me
helpful.
then, right?
So
If you're a good enough guitarist in one of those big rock bands, these days you don't have to change your own pedals to change the tone. You have a roadie who does it for you. I found that out last week.
Would you like to be
the guy from
after
News doesn't have a
Gracie
pedal.
can come off mute?
All right, we're asking him a question.
All right, sorry.
Where were we? Weren't we talking about something?
I have a couple of thoughts on this, Matt. So first, your question, no, I haven't read anything about this. All I'm kind of going back to is the two big things. One is, practicing across state lines, and the other one is being able to do video visits, without HIPAA and, doing FaceTime and whatever, right? So those have been the two big policy changes through the pandemic, right? Going more specific to, my question to you was, what were your takeaways from your conversation with Steve and Hemant and Glenn? I'd love to kind of hear that. But outside of that is, I was looking at the Q2 results for ProMedica, right? Health system in Toledo, Ohio. I don't know if you guys looked at that. So I'm just looking at it right now in Becca's. It had a net loss in Q2 of last year of 22 million and had a net income of Q2 of this year, 234 million, right? And the revenue was pretty much 1.75 billion this year and 1.72 billion in the same quarter last year. And they put this to their Paramount division, which manages 200,000+ low-income residents. So their plan, essentially, right? So that is remarkable, right? And so imagine if Jefferson had a health plan where we had 200,000 folks, and just like you said, in terms of the conversation you had with my boss, Livongo is working great for our employees, right? And other things that we're doing. But when we get to our patients, then it's really challenging because we're still paid on a fee-based service. And that's the drop in revenues that we've seen in terms of our elective practice and all this stuff. So yes, there's policy and we know that takes a long time, but the driver here is that we need to become a payer and a provider, right? To be able to deliver care. And when care goes down, we're still getting the revenues back in from a purely financial perspective. That's one place. But from a health of our individuals perspective, health of society perspective, that makes a lot of sense too as well. So that's where I would go. Less policy, more kind of operational. And I don't know if you got on that with Steve or not.
Well, a little bit. I mean, the question I had for the group is that this, you're then talking about, that this has been, so Ian Morrison's on this week, but always called this when I was growing up at the Institute for the Future. He called this the mutual disrespect problem, right? Which is that the payers always thought it was easier to be a provider. The provider always thought it was to be easier to be a payer. And in fact, when you did it, it was hard. And people have, this has been tried before. So the question is, why would it be different? And the other issue is that I don't see United or the various Blues plans or Cigna or whatever wanting to get out of the way. I see them wanting to get into the business of being providers, not buying hospitals, but buying, all kinds of other things that are either online services or physician groups, right? And that's, you look at Humana the last couple of weeks, big investor in Oak Street, put money into Heal, they're all lining up their pieces, not including the hospital. It looks to me like the inpatient hospital part is something that, as we used to talk about in the 90s, you could buy kind of on the margins relatively cheaply and, have that overcapacity go against each other. It's a bit like trying to rent out an apartment in San Francisco at the moment, which sadly I'm trying to do. It's not a good time to be doing it. Devin, I don't know if you've got
on Airbnb.
Yeah, well, maybe. But but you know, my sense is that that's the approach. And I don't know if there's room for, there may be room for one Jefferson. I'm not sure there's room for Jefferson and Penn and, you know, what's it, Keystone, or whatever the ones in your neighborhood, or the several, you know, systems there are in the Northeast or in the West or wherever, to all do this at the same time, unless somehow collectively the industry goes to the provider industry goes to the plans and goes to the government and says, we don't want to be paid this way anymore. We actually now want to come onto some kind of risk-based global budget capitation, something like that, which will mean that we, you know, are there incentive to actually start thinking about, does a Livongo or whatever that system is make sense for all our population? And I'm not hearing it from either end. I'm not hearing enough from the providers. I'm not hearing it from the policy folks. And don't forget, in the Obama administration, there are a bunch of policy people who were trying to push this, as you know, Devin. So
Matthew, I want to go back to the policy thing for a brief moment. And I was involved sort of semi-tangentially in the 2008 Obama campaign as one of the sort of outer circle of healthcare advisors. But one of the things that I learned, as opposed to being a wonk, was that the purpose of a political platform and a campaign is to win the election, not to make wonks happy by talking about every possible issue. And so all those things that we might want to talk about, ask yourself how many voters are out there talking about provider payer consolidation or health 2.0 apps to be used in improving healthcare effectiveness, right? And so if you listen to the convention, what are they talking? What do people care about? Average people care about access and cost. And then the industry, which is very important, the special interest of all the providers cares very much about what Raj was talking about. Keep those guidelines suspended so we can have telehealth across straight lines. And by the way, if you could pay us at in-person visit rates for the foreseeable future, we wouldn't complain, right? So you have to differentiate between the policy details that someone will do once they're elected and the whole process of getting elected. And when you're getting elected, the less you can say, the better, right? Because there's always somebody who will hate you because you say payers and providers, you know, need to consolidate as opposed to how many people care or whatever, versus somebody who is going to love you, say access. So you have to look at this through a political lens, not through a wonk lens. And then, of course, the Biden transition team is worried about all the details, and the Trump transition team is worried about how you build a wall. So that's kind of how I think you have to look at what they are talking about and what they're deliberately not talking about.
So, just to raise
this is a market basket issue, you know, because I mean, Michael brought up something that, you know, this is my lane. You know, I do understand the policy and the payment pieces. I understand the provider point of view. I, you know, talk to people from all points of the compass all day, every day. But when it comes down to this, there's going to be a huge reckoning as a result of the last, let's say, decade, and particularly the last 8 months. There's going to be a big reckoning with those very people, the end user, the patient, the ones I like to call people, because a lot of them are now a little more awake to some of the broader strokes of what this, you know, sort of provider payer thing is. And they're about to say, we don't really, you know, give AF about this. We just want you to fix this now. And if you are being seen to not fix this, and yes, that means asking us, the community, what we need, that, you know, unless we're invited to the table, it's probably going to be an ugly moment. Unless things go against us on November 3rd, at which point, however bad we think things are now, they'll just be worse. So stay tuned.
But in terms of, can I just jump in?
Yeah, Raj, come.
In terms of healthcare, I agree with Michael, what you're saying, but I think the most acute point right now is that the numbers of people unemployed who have then lost their insurance, that is the most acute point right now.
Exactly.
Going to,
that's the reckoning.
Going to Stephen Hemann's book that you've, I'm sure, read, Matt, what they're saying is that health insurance is going to be when you get into a catastrophic car accident and you need to have multiple surgeries and go through the ICU, it's going to cover that, and everything else you're going to buy as a consumer, right? That's their model that they talk about numerous times in the book. It's interesting. I'm not sure I agree with it, quite frankly, and it's right for this country.
I'm glad you learned something in the SPS at Cambridge.
That sounds like consumer-directed healthcare. That people have been
I mean,
complaining
if you lost your job, what are you going to do? What are you going to put your money in terms of you, your wife, your kids, and your other dependents, right? I think that is something that I'm not hearing enough about on the election trail right now.
But that's a payment structure, right? So there is, if you lost your job, you're on Medicaid or whatever, okay, you could argue that you could put money into some kind of subscription account and that would pay up to some level of high deductible. That's kind of like the HSA idea from way back. And then maybe that, and then you could also argue you could spin off small parts of healthcare to be cash paid. And that's, I think, where things are, the Roe and the HIMSS and the Keeps are all going, can we, maybe even individual telemedicine, although telemedicine visits are going up in price now. I've noticed since the demand has gone up, there's $75 cash price now, used to be 40. But the point, the point comes down to is that, as Casey, you well know, is that people who are sick are expensive, and you have to deal with that somehow. And you have to get to the point where you have to funnel money to people treating people who have severe chronic illness or have acute illness or cancer, what have you. You've got to figure out some way of funneling money to an organization so it can manage those people and not go bust, if something else happens, if COVID happens or if demand falls or whatever, if they're not making money, but if they're not being able to cross-subsidize from bariatric surgery or wherever they make their money, right? So I mean, that's the conversation which the ACO, we heard a lot about the ACO and alternative payment models, and we still have had that through the Trump administration, but they still are. I mean, you tell me, Raj, what share of money coming in the door at Jefferson, comes in one of those packages? Less than 20%, I guess. What share of money coming in the door? My question was, what share of money coming in the door is not fee for service, but is some kind of,
it's about 20.
Yeah. I mean, so it's not really material for most Americans who are outside of Kaiser or Geisinger or whatever. So that's always been the problem, is that we've got to somehow that change has got to happen. And you can argue. Go ahead.
I don't think the problem is that payers don't want to capitate or otherwise fix payments to hospitals. I think they would love to do that. I think A, the hospitals don't want that, and B, they don't have a good mechanism figuring out how do I figure per what? I mean, hospitals don't own the patients. Patients can go to different hospitals. So it's not a lack of willingness. It's a lack of I don't know what that really looks like.
But that's why it works for Kaiser. It's, because Kaiser, you're inside the bus at that point.
Right.
Yeah, but Kim, I've always wondered why the payers don't push harder on this, because everybody says that's the kind of payment model they want, and yet we don't have that many examples of it around. So who's not pushing hard enough?
Devin, I have tried to capitate hospitals. It does not go well.
Well, also, there's two things. First of all, the payers often
Too bad. Well, we won't pay you unless you take this.
The health insurers, first of all, the more money flows through the system, the more they take off the top for administrative and other kinds of things, right? Second of all, Kim's absolutely right. It didn't go well. And then third, if you go to the ultimate payers, as a former HR consultant, the actual payers are who? The employers and often the government. The government doesn't want to take the political heat, God knows. And the employers don't really want to take the political heat. And so, the employers, with the exception of the very few who we keep on reading about time and time again, really don't want to push the providers too hard because, as a saying I learned at Mercer, make sure the CEO's wife's gynecologist is in the network.
This is a good role.
It's relationships. And so, nobody really wants to push my doctor, my hospital too hard. The hospitals are making it through fee for service. And so it becomes a kabuki dance. And so you do it through little kinds of things that nobody knows about, right? So nobody knows about the CMS value-based purchasing program. Is not a political football. And so you can kind of do the pressure slowly and slowly. But as soon as it becomes political, it's, what are you doing? Am I an expenditure target? Am I rationing? Am I death panels? And so you have to have jargon that nobody understands, and then you can do it.
That's the permanent problem, right, which we've always had. And the question is the, where Casey came from is the crisis big enough that, we can actually force the needle? We used the last crisis to force the needle and, at least to expand insurance and do some other stuff behind the scenes in the ACA. But even that was very close, right? It only just squeaked through, even though there were 60 Democratic seats at one point in the Senate.
Yeah, well, I mean, have enough people lost their jobs that we could see the end of employer-sponsored insurance? Because that's been something I've been fighting for probably 15 years now.
But the problem with that case is that is the people who lost their jobs, predominantly, I mean, it's back to who suffers, right? I mean, it's what Ian Morrison says, the people taking the early bus, right? It's people who are working in restaurants, working in service businesses, working stuff where people go, all the stuff's been closed down. There have been layoffs in some tech companies, but not many. And if you go look at the stock market, I was kidding about it, but the stock market is crazy high. But all the gains in the stock market have been in a few sectors, particularly the 5 biggest tech companies, right? Who've been making money hand over fist through this thing and expanding their market power, even though we've now had, and in fact, kind of one of the quasi hopes for healthcare is they expand their market power into hope or not. But there's been all these discussions about, do they come into healthcare? And one of the things that went wrong last time when Kim was trying to get hospitals to take capitation, I don't think the hospital will ever figure it out because the hospital is a hospital. But I do believe that, those at-risk medical groups and associated entities like that, whether it's the new Teladoc Livongo or whether it's Oak Street or Iora or, maybe One Medical or maybe Jefferson changing his skin or whatever, will be able to do that again. And you're now starting to see these publicly traded, very highly valued medical groups, One Medical anyway, and Oak Street at least have got out the door already, that are starting to remind me a little bit of what happened in the early 90s in Southern California, where you had a bunch of medical groups that came out, started taking capitation, started basically reducing the number of hospital admissions, ER admissions, bed days per admission for all of their patients, and started scaring the hell out of the hospitals, started taking full risk. For a little while, did very well, and then got sort of hit in the butt by being screwed over by the plans back in the day. They also got rolled up into a big stock market thing, FICOR and Med Partners and Caremark with the names, and became this industry called physician practice management, which did very well for a few years and then then collapsed basically because they couldn't manage the doctors or manage the money the way they thought they could. So there's all these ideas that are bubbling up again, but my concern is that I don't really see as Michael said, I don't really see this recession has gone the right way. It hasn't put the CEO out of a job, hasn't put the right people in the firing line to actually move this around. It's like, oh, well, you used to work in a restaurant, now you're in a job. Maybe we'll argue about whether we can get you $400 a month. And by the way, they didn't renew that, so at the moment you don't.
But Matt, can I go back to Devin? What you said earlier in terms of why are the payers not pushing for value-based care? I mean, we clearly know why the providers are not pushing for it because, they've got a great deal right now where, whatever we do, we get paid for, whether it's the right thing or the wrong thing to do, or didn't need to be done, right? But from a payer perspective, we know, I think there's enough evidence out there that value-based care leads to high quality and lower cost, right? So why are the payers not driving this forward? Am I being really dumb here?
I don't think you could find a payer that is not putting some kind of value-based program out there. I think the problem is they don't have much teeth in them.
So why are they not saying, I'm getting mad as hell, you guys got to do this? Just right.
Raj, I was involved with the Leapfrog group when it first formed, okay? And the idea was on patient safety. The people being killed are your employees, right? And I used to joke with the HR people, if we could tell you would kill the right employees, your productivity would go up. But unfortunately, we can't guarantee that, right? So
this is why Michael didn't last too long in employee benefits consulting.
Yeah, well, it wasn't a good selling point, Matthew. What can I tell you? So, but the point is that the people paying for bad care are the employers, right? And what happened was the Leapfrog group started off as saying, we will not contract with you unless you do the following things with computerization and ICUs and everything else like that to improve care. By the time they issued it, it became you, the health plan, tell them to do this, okay, which is a pretty big difference. And then after it came out, and this was sponsored by the Business Roundtable, the most powerful business group, one of them in America. It's just people who are very, very well connected. It was rolled out by the CEO of Textron. And then they decided after a very short period of time that if we're telling hospitals to be safe if someone's hurt, that must mean that we're liable. And so they don't ask. And so they gave the Leapfrog group money and said, go away, you're no longer affiliated with us, okay? This is not the public, and that I've seen that happen because I've been involved with this, you know, at the grassroots a lot. The employers are deathly afraid of going head to head, really, with the hospitals, with the exception of the very few employers you read about. And the health plans learn their lesson because they're always the bad guy. And as long as the employers don't press them, they play around the edges and just make oodles of money. And of course, government is government. And so we are moving towards value-based purchasing. We are moving towards it significantly. But the reason we're moving towards it is because everybody, all the stakeholders are scared that if we don't, somebody like Bernie Sanders or the right-wing equivalent will take over and the whole party's going to end. Right? So let's move towards this because otherwise we might get single payer or everybody with HSA and then we're all totally screwed. And so that's kind of what's driving us slowly, but slowly is the operative word.
I think also a lot of providers think value-based care, that means we get extra money if we do well, which is fine, but they don't want to say if we do badly, we do a lot less well.
Absolutely.
Side only. And that's not going to work.
When are you going to go to the casino if I win, right? I don't want to.
Yeah, they want the floor very well identified, but no ceiling. Maybe the sky's the limit.
It's like trading Tesla stock at the moment. but
just keep beating up on old Elon.
No, but having said that, what I have to go back to. Having said that, you know, I think one of the things that you know, and Michael said, this is why it's so hard for the government. And this is something that Steve Klasko did say. You know, he said, if at some point some of these people have got to go away, you don't get it right, you know, you start poorly performing, you go away. The problem with saying that hospitals go away or whatever is that A, the politics of it looks terrible in any one congressional district, and B, the people who are in the worst position are the ones, you know, who are currently serving the poorest people, right? It's the rural hospitals, it's the inner city hospitals, the people with the great balance sheets, you know, the big systems, you know, the Sutters and the Providences and others, you know, they have to really hurt for a long time before they go away. I mean, Sutter recently got fined $500 million for price fixing. Decided to start COVID after he could not pay its fine because it was so poor. But found out there was an investigation, found out it wasn't that poor in the state of California. Actually toughened up and said, no, you still have to pay your fine. But I mean, you're along. I don't see how without some sort of wonky governmental intervention, which maybe will come by magic, you know, after January the 21st or whatever next year. I don't see how we get to the point of actually identifying what kind of hospitals or what kind of organizations delivering care we need where to effectively, you know, match up demand and need with supply. And maybe it happens online, maybe it happens by some kind of bigger rural health program, or, you know, more money coming to people with Medicaid in inner cities, or where we have some of these problems, need to fix them. And then maybe we do something about some of the overtreatment or what have you that the enough of us bang on about. For hospitals who are, you know, doing too much in terms of elective surgery. Although I know every single bariatric surgery done in Jefferson is justified.
It's absolutely justified.
Just to check with you that.
Well, but here's the thing. You know, you asked about the Democratic convention, and I think it was last night that, you know, the thing I remember the most is the calamari, like we all do. But anyway, the thing that I heard last night that made me think maybe, you know, maybe we'll see if this happens. But until every home across the United States, wherever it is, even if it's way out in the middle of literally nowhere, has access to broadband, all of this is just a kind of an exercise in futility, because it can be decided. It's like, well, everyone's just going to do telehealth and it's going to be awesome. Well, yeah, but that's going to work about as well for families who have to park in parking lots now outside of libraries, which have goosed their internet cloud so that kids can sit in the family van and do their homework until the batteries on their computers die and they have to go back home to charge them, if they even have computers. So it's, you know, I mean, this is all downstream stuff that a lot of the money that gets washed through this system, $4 trillion a year, pretty close, almost there. But if we can't figure out how to upstream some of that in ways that make a difference in people's lives, that push down some of the need for critical care, then, I mean, this is just a giant circle jerk that'll lead us all to hell pretty quick. We're here already. Welcome to the party, pal.
So I mean, and the joke about that, right? Not the joke, but the comment about that is that, so we have the post office, right, going through this crisis where it's being shut down. They're ripping out mailing machines and doing all this, terrible stuff. The point about the post office, and to some extent utilities, is that they're supposed to get to that last mile to people who couldn't afford it, where you the people who use it a lot, subsidize the people who need it out in the sticks or wherever. We've had a lot of talk about that. We haven't really had that with broadband, but we now know that it's completely essential. We've got to do that. There is a whole bunch of infrastructure. We're still waiting for, Trump came down from on election night, said he was going to do infrastructure. We're still waiting for the infrastructure package.
Yeah, it's supposed to be infrastructure week.
The infrastructure week's been every week since, for 400 weeks now. But we do need infrastructure. And Elizabeth Warren was on TV last night talking about childcare as infrastructure, and it damn well is. There are a bunch of social and technological and building things that we need to do, and we've got, I think, rearranging healthcare rationally with some government intervention is one of the things we've got to do. Now, I and Steve Klasko may disagree about how much government intervention, et cetera, that requires, but we've got to rationally somehow reapportion where we're spending our money. And part of that infrastructure, if you like, is getting people access to insurance. And there are still how many states without Medicaid expansion? How many more people didn't have lost?
I think it's still around 2022. Yeah.
And how many people have lost insurance and can't really get it back, can't get access to to COBRA, or can't get access to the exchanges, even though and this stuff has to wash out.
COBRA is ferociously expensive too.
And we're still early in this, in this recession. When people are still getting their money and figuring out. A lot of people who were laid off were still on the insurance plan of their companies, and that's going to start washing out. So it's going to come.
I have an idea, and I will end with this.
This is going to be the last idea, and then we're going to
No. I have an idea, and this will be my closing comment. I will note that the U.S. Postal Service cops arrested Steve Bannon today on a boat off of the Connecticut coast. But I think that if the USPS, which is in all 50 states and has like post offices all over everywhere, was linked up via the FCC, somehow they got a project going together where they became broadband hubs or distribution points for their areas. We could, and particularly with 5G, the advent of 5G, I think we'd have an idea. So the USPS plus the FCC plus 5G, let's do it. You heard it here first.
That's actually a brilliant comment. And don't forget, Walmart is trying to promote, and Walgreens is trying to promote, rural-based health centers. Why not put a health center in a post office? I don't know with that.
Yeah, the Japanese postal service, which was government owned, did something with like trying to send out Apple computers to elderly people and do something with access to computerization. But of course, Casey, for this country to do something like that presumes coordination, government action, intent, things like that, really.
Well, it's not going to happen under the current administration. We'll just say that.
No, I say we're all agreed. This entire conversation has been about what's going to happen, leading up to and into the next administration.
What if?
And if we're wrong about that, then I feel Bannon will be allowed off. Apparently, Kurt Schilling was not arrested. That was a
find me in Mexico, because that's where I'm going.
All right, real quick, let's go around the horn and think about what we're expecting for next week. So, Casey, I'll take that as being your comment that we're going to put healthcare and technology through the post office. Kim, what do you expect for the next week or two? What are you looking at?
That's not what I expect, but one thing I've been seeing a lot more of is that a lot more attention on these, what they're calling long haulers. What Mike was saying before, people have thought that COVID impacts somebody else. They live someplace else, they're older, whatever. But these are finding that if you catch COVID, it could have long-standing, months, years, lifetime worth of impact on you. And this happens to younger people on average. So once Americans start realizing that, hey, this could dramatically impact regular people's lives for the rest of their lives, I think they're going to get terrified. Yeah,
I'm just, if you're in that interest in that, Manish Junega, at Manish Junega on Twitter, buddy of mine in the UK, who is a little younger than me, so I guess he's in his late 40s, is one of those long haulers. He's in day 130 odd of it now, and it's not funny. Devin.
I'm going to be interested to hear more from the candidates, Biden and Harris about their particular policies, because frankly, I don't think you win an election by saying I'm better than that guy. Like, it may be polling well now, but I don't think it sustains itself. There's going to have to be more meat added to those bones, and I'll be interested to see what comes out now that the convention, as the convention starts to.
That's interesting, because in fact Hillary spent all of her money saying I'm better than that guy last time, and although she actually had a pretty different infrastructure plan, nobody had found out what it was, because there was this email thing.
Right, and we know how well that worked. So,
well,
Michael.
I agree with both what Kim and Devin said. I would say that as you look at the next week or so, what you're going to see is intense attention to the healthcare issue that people care about, which is access, right, and insurance, and COVID, and how we're treating the pandemic, because those are life and death issues, and they're politically salient issues. And so those are different people's plans for that, are what we're going to be talking about, because that's what's politically salient, what people are talking about. And then all of us can get together and talk about the wonky details.
Raj.
Obviously, I'm interested to see what the afterthought is after the Democratic convention. But also, just on the basis of the discussion today, my closing thought would be, are we over-politicizing healthcare? And maybe we actually need less politics in healthcare to actually, what Casey was saying, not do this on a 4-year cycle. Actually, let's have a 10-year cycle plus, and actually put strategy forward which has impact. It's never going to happen.
It's a nice thought. So I'll leave you with a couple of comments. I think as hospitals, health plans, and others, and the healthcare system kind of comes back on stream to normal, there's still, to me, no real certainty about planning ahead for what happens when COVID is kind of the new normal, and that we have these consistent rolling outbreaks that maybe, as I said earlier, maybe of lower intensity in terms of death than we had before, but still are pretty intense. And I liken this to the school year. I mean, some schools and colleges tried to go back, and the University of North Carolina and others have been a disaster. My kids right now are sitting in a camp where they're doing online school in their school, but all socially distant. We'll see how that lasts. There have been problems with that across America. But we all kind of were in this thing early on, thinking it was going to be ending, sometime in the summer and the fall, we were going to get a vaccine. Realistically, this is going to have to impact planning for everything going forward. Probably a year and a half from now. And, whether you're a sports league, you're a hospital, you're an education establishment, you're a workplace, maybe bowling will open up in Philadelphia, Raj, it's all going to be fine. But my sense is that, this is going to come back everywhere. And we're going to have to be like New Zealand, right? We're going to have to be vigilant about it popping back up again. We're not starting, unfortunately, the good place New Zealand was in, where they'd eradicated it. But, you're going to have to pay attention. And I am not hearing enough from all those players, maybe a bit in the education circle, maybe a bit in healthcare, about thinking about what the long-term impact of this is on their businesses. And I think those conversations are going to come up. But you're right, they may get everyone by the end of the convention, by the Senate committee report on Russia, by, Steve Bannon being arrested on the boat and God knows what else, because we do have this election that's going to dominate everything coming up in, how many days is it? Kamala Harris keeps on saying it, 78 days, whatever.
It's somewhere over 70, but
somewhere over 70 and less than 90. All right. So that's it. That's the end of the THCB gang for August the 20th. I really want to thank my guests. Another great impassioned conversation. Great to have Casey Quinlan, who's calling herself a comedy health analyst at Mighty Casey, with her own podcast, Healthcare is Hilarious. Well, worth checking that one out. Thanks, Casey. Thanks, Michael Millenson, President of Health Quality Advisors. Thank you to Devin McGraw, Chief Regulatory Officer at Citizen, braving the smoke in San Francisco there. Kim Bellard from the new home of what do they call it? Tolerance and forethought in baseball, Cincinnati. That's an inside joke because the Cincinnati Reds had to fire their. Marge Scott hired this guy, clearly had to fire him last month for some remarks he made. And Raj Agrawal, all the way from Philadelphia, Jefferson Health System there. That's the group on THCB Gang. We'll be back same time next week, 1 o'clock Pacific, 4 o'clock on the East Coast on the 27th of August. But thanks for your time. Hope you enjoyed the show.